Good evening, everyone. Welcome to all of you at Coffee Over Critical Care Cases Forum by Poland Healthcare. Dear all, it's my honor to introduce Dr. Parikshit Prayag. Sir has done his MD, ABIM, ABMS, and he is a consultant transplant infectious diseases. Sir is a director of infectious diseases, fellowship director relief center of Dinanath Mangeshkar Hospital, Pune. Sir is also associate the consultant infection disease at King Edward Memorial Hospital, Pune. Sir is a section editor for infection diseases, Indian Journal of Medicine and Pediatric Oncology. Sir is also a reviewer of infection diseases, Indian Journal of Critical Care Medicine. Sir is member of editorial board for Journal of Clinical Infection Diseases Society of India. And Sir has contributed more than 28 publications with his academic excellence and practical knowledge, and also contributed a complete chapter in more than 16 highly recognized and renowned books, journals, handbooks, which are learning stone for many doctors across the globe. Sir has professional membership and affiliation at IDSA, ESCMID, and Infection Disease Association of California, then the Transplantation Society, Indian Medical Association, American College of Physicians, Medical Board of California, USA, Maharashtra Medical Council, member of Pune Knowledge of Cluster at the time of COVID-19. So, sir, we request you to please address the quorum. Thank you.
Yes, good evening, everyone, and thank you for the kind introduction. I'll just start by sharing my slides. Thank you once again to Poland for the kind invitation. I'm going to be talking about management of carbapenem-resistant Acinetobacter infections. And as we all know, in our hospitals, the main gram-negative organisms are E. coli, Klebsiella, Acinetobacter, and Pseudomonas. So these big four bugs, unfortunately, are highly resistant in the Indian settings. So this is data from our own hospital just to put things into perspective. And these are all ICU isolates, and these are all bacteremia isolates. So if you look at the bacteremia numbers in the last 3 or 4 years, then the one that stands out in terms of carbapenem resistance is Acinetobacter. And ICMR, through the National Center for Communicable Diseases, also publishes data across India. And unfortunately, the numbers look similarly scary. So there is a very high percentage of carbapenem resistance for Acinetobacter throughout the country. Next is Klebsiella, and many centers report about around 40, 50, 60% carbapenem resistance for Klebsiella. And Pseudomonas and E. coli are on the relatively lower side. So if you look at these numbers, then you will agree with me that Acinetobacter carbapenem resistance is very, very high, and hence it's a difficult pathogen to treat in our settings. So let's look at some of the mechanisms of resistance before we actually go and deal with how to treat carbapenem resistant Acinetobacter infections. So here you have a gram negative bacteria, and here your beta lactams are going to enter through what are known as the porin channel. So this purple channel is a porin channel. It is going to go and bind to the penicillin binding proteins and try and disrupt the formation of the cell wall. So it's going to try and disrupt the cross linkages and disrupt the formation of the cell wall. Now, during this path, there could be resistance at several steps. Remember, our beta lactams are our penicillins, cephalosporins, carbapenems, and aztreonam. Now, if you look at this, this is a modified porin channel, which means that the beta lactams cannot enter at all through this porin channel. Then you have what are known as efflux pumps. So these efflux pumps are going to kick the beta lactam drugs out in the opposite direction. Then you have enzymes known as yeah. Then you have enzymes known as beta lactamases, and these beta lactamases are going to be destroying or hydrolyzing our beta lactams. And last but not the least, you could also have mutations of the penicillin binding proteins, whereby a mutated penicillin binding protein will not be able to bind to a beta lactam antibiotic. Now, if you look at the beta lactamases, which are important enzymes that destroy or hydrolyze the beta lactams, Depending on the substrate, there could be various types of beta lactamases. You could have penicillinases, or you could have AMP-C, or you could have ESBLs, or you could have carbapenemases. So if they destroy only up to the penicillin class of drugs, they would be penicillinases. If they destroy up to the third generation of cephalosporins, so typically up to ceftriaxone, ceftazidime, cefeprazole, and spare the fourth generation, which is cefepime. These would be known as AMPCs. And some organisms have inducible AMPCs, which means that once they are exposed to a beta lactam drug, then the AMPCs become active or they are expressed. And these are typically your spice groups, so Serratia or Pseudomonas or Citrobacter, Enterobacter. These are the kind of organisms that have inducible AMPCs. Then you have what are known as pancephalosporinases or extended spectrum beta lactamases. So something like CTXM that is going to hydrolyze all our cephalosporins. And then last but not the least, you have carbapenemases, enzymes that are going to destroy or hydrolyze our carbapenems. So KPCs, NDMs, or the OXAs, these are the kind of carbapenemases that we see in clinical practice. Now, where does Acinetobacter fit into this scheme of things? So we'll take a look at this. Now, there is a more formal way of classifying these enzymes. This is known as the Amler's classification. So there you could have class A, B, C, and D. In each class, there are several different enzymes. So I won't get into the details of that, but a lot of labs use what is known as the Amler's classification. So now let us look at what are the important Acinetobacter enzymes. As I said, that Acinetobacter is highly resistant to carbapenems in our settings, and more than 90% or at least more than 80% isolates in many of the hospitals in India are carbapenem resistant. And the reason is that these are the five main enzymes that Acinetobacter produces in the Indian settings: the NDM and its own OXAs. So NDM is the New Delhi metallobeta lactamase. It's a class B enzyme. You must have all heard about it. This is the New Delhi metallobeta lactamase. It's a zinc-based enzyme. Its location on the cell is very, very different, and it's a very, very potent enzyme. So it can hydrolyze all our beta lactams except astronam. All our beta lactams are hydrolyzed by the New Delhi metallobeta lactamase. And the unfortunate part is that in clinical practice, we don't have a good beta lactamase inhibitor to take care of the New Delhi metallobeta lactamase. So whether it's tazobactam, avibactam, or relibactam and vaborbactam that you have in the US, these are not BLIs that are going to be able to inhibit the New Delhi metallobeta lactamase. So NDM is an important enzyme. It's produced by all organisms, and E. coli, Klebsiella, Pseudomonas produce it plenty. But we are going to be talking about Acinetobacter tonight. So it's an important enzyme when it comes to Acineto. A lot of our Acineto isolates produce the New Delhi metallobeta lactamase. I'll tell you some of the data that we have published in terms of what enzymes are produced by Acinetobacter. And then Acinetobacter has its own OXAs. So OXA 23, 24, 51, 58. These are, remember, non-OXA 48 OXAs. So OXA 48 is something which is produced by the Enterobacteriaceae, whereas the other OXAs are produced by Acinetobacter. So let us simply remember that Acineto, when it comes to carbapenem resistance, the main mechanisms is the production of beta lactamases, and there you have carbapenemases and NDM and its own OXAs, so 23, 24, 51, and 58. If you can remember these five enzymes, these are the most important mechanisms of carbapenem resistance for Acineto. So again, the New Delhi metallobeta lactamase, which is a class B enzyme and which is unfortunately not inhibited by any of the beta lactamase inhibitors that we have in clinical practice, and then its own OXAs, 23, 24, 51, and 58. These are produced by Acinetobacter. This is what makes it resistant to carbapenems. And what did we say? The NDM is not inhibited by any BLIs, so are the other OXAs. So right now, whatever we have in clinical practice, tazobactam, avibactam, relibactam, and vaborbactam, they do not inhibit any of the Acinetobacter OXAs. So really, I don't have a good beta lactamase inhibitor for these enzymes. Durlobactam, which is going to be combined with sulbactam and which has already undergone phase 3 trials. I'll show you the attack study later on. That is the first beta lactamase inhibitor which has been shown to inhibit the Acinetobacter oxas. Till now, whatever we have, clavulanate, sulbactam, tazobactam, avibactam, relibactam, and vaborbactam, none of these can inhibit any of these Acinetobacter oxas. When it comes to enterobacterial oxas, so if you talk of E. coli and Klebsiella, we have OXA 48, and that OXA 48 is inhibited by avibactam. So we have a good drug for that, but we don't have any good beta lactamase inhibitor for our Acinetobacter oxus. Neither do we have anything for our New Delhi metallo-beta lactamase. And guess what? Aztreonam, eh, there is inherent resistance. So Acinetobacter is inherently resistant to Aztreonam. So that means that when I have a carbapenem resistant Acinetobacter which is producing these enzymes, I really don't have any good beta lactam or beta lactamase inhibitor combination to fall back on. Because let's say I would have had Klebsiella, I can use something like ceftazidime avibactam plus Aztreonam. Now here the problem is that avibactam cannot be inhibiting any of these enzymes, and Aztreonam there is inherent resistance. So remember that if there is one thing that you can take home from this lecture is that ceftazidime avibactam plus Aztreonam is not a drug to be used for Acinetobacter. Acinetobacter is a very different organism, and it has different enzymes, and that's why I'm spending a little bit more time on this slide. So again, NDM, OXA 23, 24, 51, and 58. And none of the beta lactamase inhibitors that we have in clinical practice right now are able to inhibit any of these enzymes. So, what enzymes does Acinetobacter produce? And this is something that we published last year. So, in India, a lot of our Acinetobacter isolates commonly produce OXA 23 and NDM. You can see that there are various patterns of enzymes when it comes to carbapenem resistance, and these are the isolates over a year in our settings. So, these are only bacteremia isolates. So, look at that. NDM only is rare. Commonest is something like OXA 23 plus NDM. So OXA 23 and NDM are very important enzymes. So you will see OXA 23 only, some are producing OXA 51 plus NDM. So like I said, it's a combination of these enzymes, NDM, OXA 23, 51, 58 and 24. But very commonly we have OXA 23 and NDM, and this is our common experience. Now, what about other drugs? So when we said that beta lactams are poor choices because we don't have a good beta lactam or a beta lactamase inhibitor combination to combat this type of Acinetobacter infection. What about aminoglycosides, minocycline, tigecycline, fluoroquinolones? Now, aminoglycosides are disappointing. There is a good 80 to 90% resistance for aminoglycosides when it comes to carbapenem resistant Acinetobacter. So that's disappointing. Even the newer aminoglycoside plasomycin is showing high resistance for Acinetobacter. So plasomycin, which is slated to be coming to India in the next maybe 6 to 12 months, it's going to be a good drug for E. coli, but for my Acinetobacter, it's not going to add much. Fluoroquinolones have again very high resistance in India. Phosphomycin has very poor Acinetobacter activity, so that's gone as well. Most of the carbapenem resistant isolates of Acinetobacter are also resistant to Bactrim. So I'm left with very few options when it comes to Acinetobacter. One of the decent options I would say is the use of tetracyclines. In that, doxycycline has high resistance in our setting. So what we can hope to have susceptibility for is minocycline and tigecycline. Amongst those, in some centers, there is higher susceptibility for minocycline, such as our center. In our center, we have a 50% sensitivity for carbapenem resistant Acinetobacter. So remember, the data that I am showing you is only for carbapenem resistant isolates and not for all isolates. So if you look at data for carbapenem resistant Acinetobacter, then we have around a 50% susceptibility for minocycline and about a 20% susceptibility for tigecycline. An important take-home message there is that ask your lab to test for minocycline if they have given you tigecycline MICs and vice versa. Now, TET-B mediated resistance makes minocycline resistant, whereas TET-X mediated resistance makes tigecycline resistant. So, you cannot extrapolate the MICs of minocycline from tigecycline and vice versa. So, you can have a situation in which it is minocycline resistant but tigecycline sensitive. Similarly, you can have a situation in which it is tigecycline resistant but minocycline sensitive. So you cannot extrapolate the MICs of one from the other. So always ask your lab for this. Now, eravacycline, which is a newer tetracycline, is actually showing higher susceptibility numbers than minocycline or tigecycline. So that could be a good option if and when we have that in India. So right now, tetracyclines are one good class of drugs to use from. Of course, good old polymyxin is one of the classes of drugs that we can choose from polymyxin B or colistin depending on the site of infection. And then sulbactam is another promising drug that we can use in this type of a situation. So what about carbapenem resistant acinetobacter infections? The first question is that when you have such an infection, can you use monotherapy or combination therapy? Now till 2019 or even 2020, this was a little debatable. Some experts used to favor using monotherapy. Some said that we need combination therapy. In fact, if you look at the international consensus guidelines on polymyxins, which were published, I think, in 2019, they had a 25-member panel and they were asked to vote on whether we should be using polymyxin monotherapy or combination therapy for acinetobacter. And they voted 13-12. So that's how close the verdict was. That some felt that we should be using monotherapy, some felt that we should be using combination therapy. In the last few years, IDSA has put up a little bit or has taken a little bit more definitive stance, and now they are saying that we do recommend use of combination therapy. And these are some of the studies behind it. So it's nothing groundbreaking, but you will see that there is some benefit when it comes to combination therapy as against monotherapy. So in the latest guidance, in the 2023 guidance on treatment of gram-negative infections, what the IDSA is saying is that the panel favors the use of combination therapy for CRAB. CRAB is carbapenem-resistant Acinetobacter baumannii. So the panel favors the use of combination therapy for CRAB infections for the following reasons. There is not a lot of data supporting the use of monotherapy. So let's say I am minocycline sensitive. Can I use minocycline? Then there's not a lot of data on that. I say that if my MICs are good, the patient is stable, there is good source control, you can use it. World over, if you see the case reports which have been published, there is about a 70% success rate when it comes to minocycline monotherapy. What about polymyxin monotherapy? That's a little bit harder to use because of a lot of pharmacodynamic limitations of polymyxins, and that's why now we don't label polymyxins as susceptible. They are either labeled as intermediate or resistant, and that's because we are struggling to achieve PK/PD numbers in a lot of our patients. So we are moving away from monotherapy. We are moving towards combination therapy, except a few patients in between wherein you will have stable patients, good source control, line has been taken out. So you can use something like minocycline monotherapy. But in general, for most serious infections with carbapenem-resistant Acinetobacter baumannii, the Infectious Diseases Society of America is favoring the usage of combination therapy. Now the question is that we all agree that combination therapy probably does offer something over monotherapy. The question is which combination. So the answer to that should not be automatically carbapenem plus polymyxin. So polymyxin plus meropenem actually has been shown to not add much over polymyxin monotherapy for Acinetobacter. There are two good studies published on this topic. The one study is the Overcome study and the other study is the IDA study. One which was published nearly a year ago and one which was published in 2018. Both of them are showing that polymyxins plus meropenem doesn't add much to polymyxin monotherapy. So what are we saying? We are saying that we need combination therapy, but we are saying that polymyxin plus meropenem is not a great option for our Acinetobacter. So what are our options then? So one of the models, so one of the in vitro models showed that something like a high dose sulbactam, which means that using 12 grams of sulbactam every day in combination with high dose meropenem in combination with a good dose of polymyxin can be a useful strategy. When it comes to our own Acineto, remember I showed you my data which showed that NDM plus OXA23 is an important problem in India. For this type of a combination, some in vitro studies are favoring the use of something like minocycline plus sulbactam combination therapy. And if you look at meta-analyses published world over, then a couple of them are showing that colistin, sulbactam, tigecycline had the highest cure rate, or colistin plus sulbactam was associated with a significantly higher microbiological cure rate. So what have we concluded so far? That carbapenem resistant Acinetobacter is a big problem. The mechanisms are NDM or OXA23 commonly, or sometimes the other OXAs like 24, 51 and 58. We don't have any good BLIs to take care of these type of OXAs or NDM. Astronam has inherent resistance. So ceftazidime avibactam plus astronam should not be used as a combination regimen or should not be used at all for Acinetobacter infections. And we said that we have a high resistance for aminoglycosides and fluoroquinolones. Then we said that use combination therapy. And then we also said that, but don't use polymyxin plus meropenem. So you would be thinking in your mind that, if I have to combine all these statements, what am I left with? So that is what you are left with. Either triple regimens like polymyxin, meropenem plus sulbactam, or poly plus sulbactam, or poly plus sulbactam plus minocycline. So these are the kind of regimens that we are recommending using for Acineto. So how do you choose out of these regimens? A part of this is the site of infection, toxicity profile, and so on. So when it comes to sulbactam has decent penetration into most body sites. There were some initial concerns with CNS penetration of sulbactam when ampicillin sulbactam was studied in some meningitis models, and this was many years ago. But apart from that, in most other body compartments, sulbactam has pretty decent penetration. When it comes to minocycline, again, CNS is not that great, but it's much better than tigecycline. Urinary tract is not that great again. So IDSA does say that use tetracyclines with great caution when it comes to urinary tract infections. When it comes to tigecycline, blood penetration is very poor. So tigecycline is a drug which is best used for skin, soft tissue, and intra-abdominal infections. That's where you really get a lot of high concentration for tigecycline. For bacteremia, you get only less than 1% of the drug in the blood. A lot of the drug is actually redistributed into the tissues. So at the end of 1 hour after giving tigecycline, 99% of the drug goes and sits in the tissues. So we have to bear in mind some of these limitations. So let's say I had a bacteremia with carbapenem resistant Acineto, and the minocycline MICs are decent. I might use something like minocycline alone, or mino plus sulbactam, or mino plus polymyxin. Let's say mino is also resistant, then I might go for a triple regimen like polymyxin plus sulbactam plus minocycline. So these are the kind of regimens that you can use with. Again, another meta-analysis which is showing that colistin with high dose sulbactam might be a good regimen for our Acinetobacter. So remember, focus on this word high dose sulbactam, because the kind of dosing that cephalosporin sulbactam offers you is not adequate for treating carbapenem resistant Acinetobacter. That's more of a dosing for your ESBL infections, or for your enterobacterial UTI. When it comes to crab infections, we are recommending 8 to 12 grams of sulbactam. 8 to 12 grams of sulbactam. We'll hear a little bit later on when we have a discussion with some of our nephrology colleagues about the dosing of sulbactam in renally impaired patients. Now, so one of the important aspects here is polymyxin PKPD. So polymyxin is a drug for which we look at something like AUC by MIC. And we need very high AUC MICs to take care of pulmonary infections. So when it comes to Acinetobacter, let's focus on Acineto. Let's forget Klebsiella for the time being. So if you look at Acinetobacter infections, we need an AUC MIC ratio of more than 100 for pulmonary infections, and about 15 to 20 at least for our bacteremias. Now, what about the AUC? So how much AUC are we really achieving for our patients? And this is something that I try to do at the bedside. What is the kind of AUC that we are generating for our patients? So if you do have access to therapeutic drug monitoring, then you can have a rough idea of the AUC. So a trough concentration of around 1 generates an AUC of around 30 for polymyxin, and a trough concentration of around 1 generates an AUC of around 25 for colistin. So which means that if I have access to therapeutic drug monitoring, I can have a rough guess of the kind of AUC MICs I am generating. So look at the last 8 patients on whom we have done polymyxin therapeutic drug monitoring. Look at their polymyxin levels and look at the AUCs that we are generating. For the first patient, polymyxin trough was around 3.7. So maybe we are generating AUCs of around 100. The next patient 1.4, so multiply that by 30. So maybe we are generating AUCs of around 35, 40. Next patient 0.9, so maybe we are generating an AUC of around 25 to 30. So if you look at these AUCs, look at patient number 5, we are generating an AUC of barely 3 to 5. So if you look at these type of AUCs, now we have to divide them by the MIC, and for a lot of the patients in our settings, the MIC is between 1 and 2. So then you will realize the kind of AUC MIC ratios that we are generating. And that's why when it especially comes to pulmonary infections, it's very, very difficult to generate an AUC-MIC of more than 100. To generate an AUC-MIC of more than 100 is very, very difficult when it comes to pulmonary infections. So that is one of the main problems. In that sense, polymyxin B is a little bit better than colistin, but still it's a struggle, and that's why especially for pulmonary infections, it's very, very difficult to use polymyxin monotherapy. Now, does nebulized colistin add much over it? One of the studies that has been published, I believe it's from Singapore, suggests that it doesn't add much. There's no harm in trying as a supplemental therapy, um, but there's no good data on that. Most people will use it in addition to systemic therapy. There again, be mindful of the kind of colistin doses that we are using. So if you're using nebulized colistin, make sure that you are using high doses, not just the 1 million unit TDS dose, something like 2, 3, 4 million units every 8 hours. So we are using something like about 8 to 12, 15 million units of inhaled colistin per day. So those are good doses to use when it comes to inhalational therapy. Remember, we have to optimize the weapons that we have. So using high doses of sulbactam, using high doses of nebulized colistin, because these are the kind of pharmacodynamic numbers that we are dealing with. And just like that, we have to also optimize our minocycline dosing. So if you look at the latest IDSA guidance, they are actually advocating 200 milligrams BD of minocycline. They're saying that even up to 700 milligrams of total minocycline dose can be used in the day. So that's a little too much, but at least use doses of 200 milligrams BD for your resistant organisms. So if I have a minocycline resistant isolate, then I would use probably something like a triple regimen of good dose of polymyxin plus 200 milligrams of BD of minocycline plus 8 to 12 grams of sulbactam in the day. So that's how you like to look at it. Again, AUC-MICs are important for minocycline. Patients who have augmented GFRs, obese patients, patients in whom my minocycline MIC is going to be more than 1 or 2, these are going to be the patients in whom definitely minocycline should be used as 200 milligrams BD. There is some hope on the horizon, so we will have something like sulbactam, durlobactam maybe in the next few years. This is the attack phase 3 study in which they combined colistin plus imipenem versus sulbactam, durlobactam plus imipenem, and they found that sulbactam, durlobactam based regimen was actually a good regimen. What's the advantage here? It's the first beta lactamase inhibitor, durlobactam, which is able to take care of my oxa enzymes, and you're combining that with a drug like sulbactam, which has decent acinetobacter activity. Remember, the sulbactam here is going to be used as an antibacterial drug, not as a beta lactamase inhibitor. The BLI part of this combination is durlobactam. So durlobactam is going to be playing the role of a BLI. Sulbactam is going to be playing the role of an antibacterial agent. So in that type of a scenario, this would be useful. However, I still have my reservations because durlobactam cannot inhibit the New Delhi metallobeta lactamase. And as I've been showing you our own data, there is plenty of NDM production when it comes to carbapenem resistant acinetobacter. What about cefidericol? So cefidericol is a good drug. It's not destroyed or inhibited by the New Delhi metallobeta lactamase. So it might be a useful option, but it has to still stand the test of time. Some of the AMPCs, some of the oxas, it has to still stand the test of time. Right now, what the IDSA is saying is that use cefidericol as a part of combination regimen for acinetobacter. And eravacycline we talked about, so it's like a bigger, better version of minocycline. So a lot of the minocycline resistant isolates still remain susceptible to something like eravacycline. I'll just end by showing you this case: patient with neurosurgical meningitis and has acinetobacter, which is resistant to everything. So this is a very, very tough case. So here you are left with very few options. So maybe start, like we said, with something like colistin plus minocycline plus sulbactam. Again, I'm looking to optimize the PKPD of each of these drugs. So maybe IV colistin plus intrathecal colistin, something like 1 to 1.25 lakh units intrathecally, plus IV good dose 9 million units loading plus 4.5 to 6 million units BD. Good IV dose, good intrathecal dose. Be careful of the local inflammatory reactions that it can produce, but a good intrathecal and a good IV dose. Maybe something like 200 milligrams BD of minocycline, maybe something like 12 grams of sulbactam. So these are the kind of constraints that we have. If this is not working, maybe add something like a phosphomycin. It adds very little to an Acinetobacter regimen, because out of the four big fours, E. coli, Klebsiella, Pseudomonas, and Acineto, phospho has the least activity against Acinetobacter. So you will see a few case reports of phospho or rifampicin being used as part of combination regimens, but those are when things have become very, very desperate. So if these three are not working, maybe something like phosphomycin, rifampicin, but again, those are very, very dire situations. So I will summarize by saying that carbapenem resistant Acinetobacter infections are a big problem in our settings. There is a high amount of carbapenem resistance. The main enzymes are indium. Again, we've been saying this throughout the last 30 minutes. Indium, OXA 23, 24, 51, and 58. These are our main enzymes. Um, Out of these, none of them, OXA 23, 24, 51, 58, as well as the NDM, none of them can be inhibited by either clavulanate, sulbactam, tazobactam, avibactam, relibactam, or weberbactam. So none of the BLIs that we have in clinical practice are able to inhibit our Acinetobacter carbapenemesis. Aztreonam has zero activity against Acinetobacter. So ceftazidime avibactam plus aztreonam is not a good combination. Consider at least two agents whenever possible. But polymyxin plus meropenem is not a great regimen. So try to use drugs like minocycline, tigecycline, sulbactam as part of your combination regimens. If one of these is clearly sensitive, if minocycline is sensitive, patient is stable, can use it with careful monitoring. If polymyxin is the only choice, then best used as combination therapy, especially for pulmonary infections, because the PD targets are high. Be mindful of the kind of dosing strategies that we are using. So we've been stressing on high doses of sulbactam, minocycline, and use your combination regimens well. So these are the kind of strategies that we need. Amongst the drugs to look forward to, eravacycline and sulbactam, durlobactam, and cefderichol. These are three promising drugs when it comes to Acinetobacter infection. So I think I'll stop here, and I'll hand it over back to the moderators. And I think we have the honor of having Nayak sir with us, who is going to be sharing his wisdom on using sulbactam in renally impaired patients. So it's my pleasure and honor to welcome him to the panel, and then we'll hear his thoughts for about 10 minutes, and then maybe we'll take a few questions if that's okay.
Thank you so much, Doctor, for presenting on management of carbapenem-resistant Acinetobacter baumannii. And as Sir has rightly said that Dr. Nayak is also with us. So let me introduce, it's my honor to introduce Dr. Nayak, who is going to put a light on dosing of sulbactam in renal patient. Dr. K.S. Nayak is a MD, DNB, FRCP, FASN, Head Department of Nephrology at Ritchie Hospital, Hyderabad, and internationally acclaimed nephrologist, known for his path-breaking work in clinical, medical, academic, and research field. He is a much sought-after speaker in a national and international conferences. His area of professional interest includes ICU nephrology, peritoneal dialysis, renal transplant, renal nutrition, and innovation use of technology, among others. Sir is also a president of International Society of Blood Purification. Sir, we request you to please address the quorum. Thank you, sir.
Uh, Thank you, the organizing committee, and especially it was an excellent exposition by Dr. Parikshit on the problems that we are facing with the multi-drug resistant, the CRAB, which is the carbapenem resistant Acinetobacter baumannii. I will focus myself and restrict myself to sulbactam in renally impaired patients. Almost every patient you see in the intensive care has renal impairment. So usage, can we use it or not? How much should we use? And what are the different therapies of renal replacement? What are the doses? I'll just restrict to that. But I would like to begin with a chance finding, say, about more than almost 1.5 decades back, that any regimen that was used, which had sulbactam in that, seemed to act more effectively in the especially the Acinetobacter baumannii. And among the three more important drugs, which is clavulanic acid, sulbactam, and tazobactam. The other two, clavulanic acid and tazobactam, are something like sidekicks to the more important thought to be more important antibiotics such as the cephalosporins. But it was realized that sulbactam has a direct bactericidal effect on, especially when we were faced with the problem of Acinetobacter. It has a direct bactericidal effect, and that was the reason. But in lower doses, it may not be that bactericidal. The higher the dose, it acts as a bactericidal agent. So this started a flurry of uh, what do you call usage of sulbactam, and the sulbactam alone became a concept, which is sulbactam alone. Uh, I think the biggest area of Acinetobacter baumannii, which causes the life of the patient, is the lower respiratory tract infections, especially in ventilated patients in the ICU. And we are desperate to save them. And I fully agree with the Dr. Parikshit that we should go for a combination therapy, though there is a small possibility of sulbactam loan therapy also. We have been using sulbactam loan for about close to more than a decade, and I think combination therapy, this is all clinical judgment, but in a very sick patient, we probably should go for combination therapy, because the data says even sulbactam, high dose sulbactam with tigecycline, or high dose sulbactam with the polymyxins and minocycline, as Dr. Parikshit has so well reviewed the literature. Now, the most patients, as I said, in the ICU are on some form of renal replacement therapy. We are one of the few units in the world which use automated peritoneal dialysis, immediate usage. We put in the catheter, the Tenkov catheter we call it, and we start immediate automated peritoneal dialysis. So the options available for renally impaired patients in our hospital, in our intensive care, are the regular hemodialysis, which we rarely use now. You all must be knowing SLED, which is slow, low efficiency. We don't tell the full form to the patient attendants, because they say you are giving a slow, low efficiency dialysis. But SLED we have turned. When I was a fellow way back in the early 80s, if we didn't get a flow through the catheter of more than 150, we used to shift to change the catheter. But now we have gone a full circle, and a flow of around 100 to 125 is also enough, and we don't need to even do it for 8 hours, but that depends on the clinical condition. So the options available for acute kidney injury or chronic kidney injury with the uh, uh, acute superimposition of acute element are hemodialysis, which is SLED most probably, the continuous renal replacement therapy, CRRTs, and we have the, as I said, we are one of the few units in the world which we use automated peritoneal dialysis as an option, and we are doing a randomized controlled trial comparing CRRT to uh, CRRT to automated peritoneal dialysis, uh, and we are getting excellent results with this. Uh, so to give you roughly, uh, when the creatinine clearance is roughly more than 30 ml per minute, uh, corresponding for you to 55 or 60-year-old person who's weighing about 65 to 70 kgs, they would have a creatinine of around 2.5. That is equivalent to a creatinine clearance of around 30. If it is more than that, there is no need to reduce the dosage of sulbactam. And I am repeatedly telling, there is some kind of inertia among all doctors, especially in the intensive care, to go to high doses of sulbactam alone, which could be sulbactam in combination or sulbactam alone. And I strongly agree with Parikshit that when we are talking of life-threatening infections, we should go towards the higher dose, even any other antibiotic. Uh, I mean, renal failure can be treated, and uh, so I would suggest that a dose of 8 to 12 grams is a perfectly reasonable dose. I have seen, in spite of me suggesting, people going for 4 grams when the creatinine has been normal. So 8 to 12 grams. There have been studies saying that 9 grams is as good as 12 grams. But that, I think, is once you have decided to cross 6, you're going into 9 and 12 grams per day. It is given, as you know, 3 to 4 divided doses. So that will be about uh, 4 grams thrice a day, or 3 grams 4 times a day. This is in normal renal function. Most of the uh, almost it can be given as IV and IM, but IV is the preferred dose. Most of it is cleared within 6 hours, but the half-life is around one and a half hours if given IV in normal renal function, and most of it is cleared by the kidney. So the kidney becomes a very important organ. So when you have a creatinine clearance below 30, which is a serum creatinine of around 2.53 and less in a normally built person, you should halve the dosage, give 50% of the dosage in 2 divided doses. And I would recommend 3 grams BD in such patients. Uh, and if you are going towards a patient who is in total renal shutdown and uric, then you should go for the half-life increases tremendously to about 21 hours. So you should go for once daily dosage at 25% of the original dosage, that is 25% of 12 grams. In a serious septicemic patient, probably on pressors, probably on artificial ventilation, and we're talking of a very, very sick patient, combination therapy, the dose of Sulbactam in such cases would be 25% of the dosage, which would be around, I would say, 2 to 3, go towards 3 grams per day, single dose. But the most important point you should remember is the first day dosage will be a 12-gram dosage. It will be the loading dose on the first day so that you establish therapeutic levels. So you give 12 grams on the first day, and the second day onwards, if the patient is on hemodialysis, you give the dose after hemodialysis, because about 40% of Sulbactam is cleared by hemodialysis. So you give a 3-gram dose post dialysis, immediately after dialysis. If it is CRRT, just take the rule of the thumb that CRRT has a creatinine clearance like a working kidney equated to about 50 ml per minute. So you can go for around uh, probably you have to give it continuously, because CRRT is running through 24 hours in a day. So you can probably go for around 1 gram every 3 to 4 times a day. That is the CRRT dosage after giving the full dose. In CAPD patients, the creatinine clearance would be around, in APD and other things, it could not cross 7 to 8 ml. So you can go for the single dose, and there is no need of dose supplementation after CAPD because or APD, automated peritoneal dialysis, because the clearance is very little. So you can go for about 2 to 3 grams per day, and there's no need of dose addition as in hemodialysis. So this is in a very succinct way. I've given you the dosage regimen in renal failure. As the patient is withdrawn of CRRT, then you can, based on the EGFR, you can increase the dose, and if the patient comes off, then you go on to the normal dosage. But I strongly agree that given in our experience, the best experience has been Sulbactam with the polymyxins, and addition of minocycline is definitely something we consider very regularly. So I would this is a summarized uh, uh, guideline for you to use Sulbactam in the ICU in the CRAB infection, the carbapenem resistant Acinetobacter. I would be happy to answer any questions, but I think Parikshit has answered almost all the questions. Thank you very much.
Thank you so much, sir, for your kind gesture on the putting the light on the dosage of sulbactam in creatinine clearance patient who has impaired. So from the quorum, if you have any questions, so please feel free to ask.
Tavasji, I think Dr. Sujitto sir wants to speak. Sir.
Yes, sir, please.
Hello, Dr. Parikshit. Good evening. Uh, thank you for a
Good
thank
evening,
you for an
sir.
excellent presentation. I just have one query and one comment regarding the dosage of minocycline, the 200 milligram BD. We have used in some patients, maybe a small group of around 10. A majority of them develop liver dysfunction within 3-4 days, and the BLI gone up to 8 to 10. So eventually, we have dropped that practice. Otherwise, in between, we have started that. So, what will be your comment about that? And another question, that if some Acinetobacter is there, which is exclusively NDM producer, is there an opportunity to give ceftazidime avibactam acetonum in that subgroup?
Yes. So, sir, I agree with you that high dose minocycline in our settings is a little tricky. High dose tigecycline for sure. I mean, a lot of us have had this experience that Indians are probably slow metabolizers for tetracyclines, and so high dose tigecycline has been a problem. With mino, I haven't had as much of a problem, but I usually use it in patients who have either augmented GFRs or who have higher MICs. So their AUCs when it comes to augmented GFRs are on the lower side, around 10 to 15, rather than someone who has had renal impairment and you give high doses, their AUCs can be as high as 60 to 80. So usually we reserve it for patients who have had augmented GFR. So my personal experience with toxicity really hasn't been that bothersome. Coming back to your question on NDM producing Acinetobacter, unfortunately, Astronom has no activity against Acinetobacter. And so even if this would be a pure NDM producing Acinetobacter, you wouldn't be able to use that combination because Avibactam, as we all know, wouldn't inhibit the New Delhi beta lactamase. If that would have been the case, we could have used an Avibactam containing regimen. But Avibactam doesn't inhibit NDM, and then Astronom, which is paired by NDM, has no Acinetobacter activity. So unfortunately, that's not an option there.
Okay, thank you.
Thank you, sir.
Thank you so much, sir, for your question, and thank you, Dr. Prakshit, for answering. Anyone else have any query?
I think Tavish, Dr. Beena from Aurangabad is having some query. She have
Sir, please, sir, please unmute and speak up, sir. Doctor, can you please unmute and ask your question?
Yeah, my question is to Dr. Parikshit. Parikshit, if we want to give meropenem in infusion, can colistin be given simultaneously when we are giving that infusion of meropenem, say in any patient who has got this MDR Acinetobacter, or you give infusions for either of them, polymyxin or colistin?
Sorry, I think I'm on mute. If you want to give continuous infusions, then of course you will have to use a part of the day in also giving polymyxins. Now, having said that, the recent JAMA study showed that continuous infusions didn't add much over intermittent infusions, but there is still plenty of evidence on prolonged infusions. So sometimes you get this situation that while the meropenem infusion is going on, you do have to give polymyxins. So you have to do that, unfortunately. I mean, there are not too many safety concerns when it comes to that. So using different sites if you give polymyxin and meropenem, because you do want to optimize the meropenem pharmacodynamics as well.
Right. And does the PKPD applicable for Sulbapol also? Yeah, Sulbactam infusions, if you give it in that high dose?
So there the dosing is important.
Yeah.
There like we've been saying, the high dose is important. So because it is not a beta lactam drug, it is independently acting as an antibacterial drug for Acinetobacter. So there the total dosing being 8 to 12 grams in the day is important.
Right. So you can keep as a maintenance dose over say 12 hours. If the patient is on CRT, you give it prior to the schedule of CRT or renal replacement, and
So
then
as
again reschedule.
as sir said, one thing to keep in mind is the half life of Sulbactam. So that's why, two divided doses, let's say a patient with normal creatinine, in two divided doses is not a good idea. So I cannot be giving this patient 6 grams BD, because then he will in the next 5 or 6 hours wash out the Sulbactam. So like sir said, because of its relatively short half life, 3 to 4 divided doses is what is recommended.
Right.
And continuous therapies need continuous Sulbactam.
Continuous.
And
But we escalate the dose to almost 12 to 16 grams. Sir? We escalate the dose to very high dose so as to maintain the levels.
in which treatment, Dr. Sanmay?
In patients who are on CRT or patients who are on renal replacement.
Patients on renal replacement therapy, I told you, hemodialysis, you treat them like anuric patients, but give them the dose after hemodialysis. That's a smart way of doing it. For patients on CRRT, you need to give it continuously because the creatinine clearance is almost 15 ml. So you need to give a little high dose, and you follow the 3 to 4 doses per day, because CRRT and hemodialysis both clear the Sulbactam. But in peritoneal dialysis patients, you can give it as a anuric patient. That's about 3 grams per day. One single dose is enough. But CRRT, you give it continuously, the same total dose of around 4 grams, 3 to 4 grams. And hemodialysis, give the 3 gram dosage after completing the hemodialysis, and wait for the next hemodialysis. On non-dialysis day also, you give the 3 grams, one single dose. Anybody having a serum creatinine around 2, you can probably give the same dose, but around 2.5 and 3, you can take a call. If the patient is very serious, I would probably give a higher dose rather than giving a single dose. This is something that is very clinically very important, that if the patient is very, very sick, I think Parikshit will agree with me, you try to go towards the higher dose. And Sulbactam, for your information, is not a very toxic drug like say polymyxins. But important thing is the first day's dose should be a normal dose, which is around 8 to 12 grams. Given
On
as
a non-dialysis, we can go up to 6 grams as a top-up dose.
No. You go, because the patient is anuric, you go 25% of the dosage, one single dose on non-dialysis days. And on the dialysis day, I'm assuming you are doing 3 dialysis or daily dialysis or whatever, give it post-dialysis. But if you are doing 3 dialysis, then on the day of dialysis, give it after dialysis. On the non-dialysis day, you can give it around the same time, but the dose is not changed. The same dose, one single dose on hemodialysis, which is generally SLED. I assume that you do SLED in your unit and not the regular hemodialysis.
And if we do SLED, I will do CRTs for 12 hours, 24 hours also.
So that time you have to give continuous dosing.
Thank you, sir.
Thank you.
Thank you so much, Dr. Sanmay, for your questions and query, and Dr. Nayak and Dr. Parikshit, sir, for answering those. Sir, we got one question from Dr. Paj Shah in a text chat box. What drug side effects need to be monitored in patient receiving Sulbactam?
Well, in general, it's a safe drug. A lot of the toxicity or adverse reaction data that you would see with Sulbactam is actually because of its parent beta-lactam drug. So, for example, thrombocytopenia or a little bit of transaminitis is actually because of the fact that there is cephalosporin with Sulbactam or ampicillin with Sulbactam. By itself, it's a fairly safe drug. Now, there are some animal models in which very, very high doses of Sulbactam have had some concerns with neurotoxicity, but that's at very high doses. So in general, at the doses that we use for plain Sulbactam, it's a very safe drug, and that's the utility I feel of having plain Sulbactam in a setting like India, because we don't need to buy the toxicity of the parent beta-lactam, which there is useless. So if I'm treating, let's say, a carbapenem resistant Acinetobacter, the cephalosporin component, apart from adding to the toxicity, is not really adding anything to my regimen. So I think in that sense, it's unlike in the US, where it's a challenge to get plain Sulbactam. We have that luxury in India.
Thank you, sir. Again, Dr. Prashant Satwalkar, sir, want to ask some questions. He has raised his hand.
Hello, good evening, Dr. Parikshit. Just
Uh,
one question. Many times we are seeing that Sulbactam being combined with meropenem as a one drug, or Sulbactam with ceftriaxone, EDTA. Are these combinations rational to use?
Short answer is no. Uh, there are several problems with it. I mean, it's so if so. For example, if I'm using sulbactam as a beta lactamase inhibitor, then there is no point in combining it with meropenem because sulbactam can inhibit only ESBLs, and mero is going to remain active against ESBL. So combining
Correct.
meropenem with sulbactam from an ESBL point of view makes no sense. From a carbapenemase point of view, also it doesn't make sense because by itself sulbactam is a weak BLI. So out of all the BLIs that
Okay,
we have, tazobactam and avibactam are much more potent. So sulbactam is a weak BLI. So really there is no point. Now there are some formulations in which EDTA has also been added as an added attraction. The
Yeah.
EDTA can inhibit the New Delhi metallo-beta lactamase, but that's in the
Hmm.
lab. So we need a
correct.
lot more when it comes to using it in clinical practice. So the EDTA dosing, the dosing of the disc, defining breakpoints, all this still remains a lot. I mean, there are a lot of question marks there. And like I always say, there is a reason that no other country in the world is
Yes.
using EDTA-based combinations in clinical practice except India.
Correct.
Parikshit,
Thank you.
you would probably want to add, uh, since you are the expert, the broth versus the disc. You say, I mean, sensitivity discs for sulbactam. We have found that the broth is the better way of doing. Would you? I would
I
like you
agree.
to. Yeah. Would
I
you?
agree.
I would like you to enlighten the
Yes.
audience here about
Right,
that.
right. I agree. So getting sulbactam MICs is a challenge, because there is very little guidance on getting sulbactam MICs. Most labs don't test for that. But I agree in theory, the broth microdilution is a better way of looking at it. Now, sometimes you can get a rough idea by looking at the zone diameter for third generation cephalosporins and third generation cephalosporins in combination with sulbactam. But that just gives you a very rough idea. But in general, I agree with you. The broth microdilution is a much better way of looking at it.
Should I think all of you should insist that with the microbiologists that's the procedure they should follow so that you get a better idea and you get convinced. And I think at first shot, 8 to 12 grams, there will be a lot of eyebrows raised. But believe me, it works. And I think Parikshit has given a very good platform for you to use this and go for the high dose, and you see you can save quite a significant number of patients from Acinetobacter from the crab. I mean, crab is synonymous with cancer, but here we call it a crab is worse than cancer. Yeah.
Any more questions from the quorum? So I think, Doctor, you have already, both of you have cleared all the queries, and that was really an excellent presentation. And thank you so much. Special thanks to Dr. Nayak, sir, so putting the light on the extended of sulbactam dosing. So behalf of Poland Healthcare, I would like to say thanks to both of you, Prayag Prayag sir and Dr. K.S. Nayak sir, for joining us for this webinar. And definitely in future, we also want to associate with you for further, like for academics and further such sorts of webinars on different topics. Thank you so much. And thank you everyone for joining us. Thank you, sir.
Thank you.